Hey, and welcome to the Docsaab's Diary. Today, we are embarking on a comprehensive journey into a critical medical emergency organophosphate poisoning. This condition, caused by exposure to toxic organophosphorus chemicals, impacts millions globally each year, particularly where agricultural pesticide use is widespread. Our aim is to provide a detailed, accurate overview directly from the latest information. Organophosphates are a vast class of organic compounds distinguished by a central phosphorus atom. They are often found as esters of phosphoric acid or its sulfur analogues or derived from a phosphonic or phosmonic acids. These compounds are chemically diverse, frequently including thiol or amide derivatives with the phenoxy, cyanide, and thiocyanate radical groups in their side chains. They can be either natural or synthetic, and with hundreds currently in use, categorized into at least 13 distinct types. They exhibit significant variation in toxicity, residue levels, and how they are excreted from the body. Most commonly, organophosphates are found in pesticides and alarmingly nerve agents. Now, let's explore the many facets of this critical topic. Organophosphates have an extensive range of application across various sectors, making exposure a pervasive risk. In agriculture, organophosphates are extensively used as insecticides to control crop pests, enhance yields, and manage weed infestation. Examples include familiar names like parathion, chlorpyrifos, diazinon, malathion, phenethion, dichlorobos, and ethion. Ethoprop specifically targets worms and other soil pests, while tribufos is used to defoliate cotton before harvest. In public health, they are employed to protect against vector-borne diseases such as dengue fever and malaria by controlling insect populations. For industrial and domestic use, organophosphates are diverse compounds found in various household products. They can be components of antihelminthics such as trichlorphone and herbicides like tribufos, also known as DEF, and murphos. Certain ophthalmic agents such as ecothiopate and isofluorophate also contain organophosphates. Tricresyl phosphate, for instance, is an industrial chemical used as a plasticizer and can also be found in the manufacture of solvents and plastics. Perhaps most alarmingly, some organophosphates are incredibly potent nerve agents, including serine, somen, tabun from the G series, and VE, VG, VM, VR, VX from the V series, as well as the notorious Novichok agents. Exposure to these compounds can occur accidentally, deliberately, often in cases of self harm, or in rare instances as a part of chemical warfare. Organophosphates can enter the body through three main routes. First, ingestion. This involves swallowing contaminated food or water or intestinal self harm. Ingested organophosphates are readily absorbed into the body, leading to rapid systemic effects. Second, inhalation. Breathing in chemical vapors is a significant risk for agriculture workers during spraying operations. Like ingestion, organophosphates absorbed via inhalation are quickly taken into the system, often with immediate consequences. And third, dermal contact. This occurs when the compounds are absorbed through the skin, which can happen through contact with contaminated surfaces or clothing. While organophosphates are readily absorbed after inhalation and ingestion, systemic absorption following dermal exposure shows more significant variability. The onset, severity, and duration of toxicity are influenced by several factors. The amount ingested or absorbed, the specific absorption route, and the particular pesticide's toxokinetics, that is, how the body handles the chemical. The widespread use and low cost of organophosphate contribute significantly to their common involvement in poisoning incidents globally. Now, let's delve into why organophosphates are so toxic at a molecular level. The primary mechanism by which organophosphate pesticides exert their toxic effect is through the inhibition of carboxyl ester hydrolysis, most notably acetylcholine esterase. Acetylcholine esterase is an essential enzyme responsible for degrading the neurotransmitter acetylcholine into choline and acetic acid. Acetylcholine plays a crucial role in signaling throughout the central and peripheral nervous system at the neuromuscular junctions and within red blood cells. Organophosphates inactivate acetylcholinesterase by phosphorylating the serine hydroxyl group located at the active site of the enzyme. Over a period of time, this phosphorylation is followed by the loss of an organophosphate leaving group. This process renders the bond with acetylcholinesterase essentially irreversible, a phenomenon known as aging. Once acetylcholinesterase has been inactivated, acetylcholine accumulates throughout the nervous system, leading to the overstimulation of both muscarinic and nicotinic receptors. The clinical effects of organophosphate poisoning are primarily manifested through the overactivation of the autonomic and central nervous systems, as well as at nicotinic receptors on skeletal muscle. Once an organophosphate binds to acetylcholinesterase, the enzyme can undergo one of three fates. First, endogenous hydrolysis. The phosphorylated enzyme can be broken down by other esterases or paraoxygenases present in the body. Second, reactivation. It can be reactivated by strong nucleophile such as pralidoxime, commonly known as 2-PAM, especially if administered before aging occurs. And third, irreversible binding and permanent enzyme inactivation. This is the aforementioned aging process where the bond becomes permanent and the enzyme is rendered non-functional. This mechanism highlights why the effects are so widespread and potentially devastating. Organophosphate poisoning leads to a wide range of signs and symptoms, which can be categorized by the affected receptor type, muscarinic, nicotinic, and central nervous system, and the onset of symptoms like acute, delay, or late. Let's start with the acute symptoms which manifest within 24 hours. These immediate effects are often termed cholinergic crisis due to the intense overstimulation of acetylcholine receptors. Muscarinic effects are often remembered by the mnemonics like slum jam or dumbbells. They include salivation means increased drooling, lacrimation means watery eyes, urination means increased potentially involuntary urination, defecations means diarrhea, gastrointestinal motility means stomach cramps, nausea and vomiting, and emesis that is vomiting, and miosis means pinpoint or narrow pupils. Other muscarinic signs include bradycardia or slow heart rate, bronchoconstriction or narrowing of airways, bronchoria, which is excessive bronchial secretions, and profuse sweating known as diaphoresis. Next, nicotinic effects. These include muscle fasciculation or visible muscle twitchings, tremors, muscle weakness, fatigue, and ultimately paralysis. This can lead to severe respiratory distress due to the failure of muscles like diaphragm. Finally, central nervous system or CNS effects. These manifest as headache, dizziness, anxiety, confusion, drowsiness, and emotional liability. More severely, they can cause seizures, delirium, and coma. Respiratory depression or arrest is a major and common cause of fatality. Patient may also experience insomnia, memory issues, psychosis, and hallucinations. Beyond the immediate crisis, organophosphate poisoning can present with delay and late symptoms. Delay symptoms occurring from 24 hours to 2 weeks post exposure and include the intermediate syndrome or type 2, which typically develops 24 to 96 hours after acute symptoms resolve, sometimes up to 114 hours post exposure. It is characterized by paralysis, especially of the muscles of respiration and proximal limb muscles, leading to severe respiratory distress. Delay onset cholinergic symptoms can appear 40 to 48 hours post poisoning, and in severe cases, delay onset encephalopathy and coma can strike around 4 to 7 days after hospital admission, sometimes even after a period of seemingly normal consciousness. Late symptoms manifesting beyond 2 weeks and can include cerebral ataxia, which can appear around 8 days post poisoning. The onset and duration of symptoms are significantly influenced by several factors. The specific organophosphate agent's rate of enzyme inhibition, the route of absorption, oral and respiratory exposure typically lead to symptoms within about 3 hours, while dermal exposure can take up to 12 hours, and the compound's lipophilicity. Highly fat-soluble organophosphates can be stored in adipose tissues, leading to delay onset and prolonged symptoms as they are slowly released into the bloodstream. Diagnosing organophosphate poisoning relies primarily on clinical evaluation because laboratory confirmation often takes too long for immediate treatment decisions. Therefore, treatment should be initiated based on high level of clinical suspicion. For clinical assessment and history, we look for key symptoms such as myotic or constricted pupils, diaphoresis, excessive sweating, and respiratory distress, along with other muscarinic, nicotinic, and central nervous system effects. The Dumbbell's mnemonic can help identify classic cholinergic symptoms. A characteristics garlic or petroleum odor might also be present in some cases, serving as a diagnostic clue. Crucially, a detailed patient history regarding potential exposure to a pesticides or other organophosphate containing substances is a vital for diagnosis. For a laboratory test, cholinesterase activity measurement is considered the most reliable laboratory test for confirming opioid toxicity. This involves measuring the activity of acetylcholinesterase in red blood cells, known as RBC acetylcholinesterase, and plasma pseudocholinesterase. RBC acetylcholinesterase is generally considered a better indicator as it correlates more closely with central nervous system activity. Fresh samples are required for accurate results, ideally drawn before treatment with pralidoxime. Monitoring serial levels can then track the response to therapy. Other significant laboratory findings can include leukocytosis, hemoconcentration, metabolic and/or respiratory acidosis, hyperglycemia, hypokalemia, and hypomagnesemia. Elevated troponin levels, amylase levels, and liver function test result may also be observed. For toxicology screens, analysis of organophosphate degradation products can be performed in stomach contents, liver, and kidney tissue, especially in postmortem investigations. And pregnancy testing may be performed for female patients to assess potential implications. Beyond lab tests, other diagnostic tools provide crucial information. An electrocardiogram or ECG often shows sinus bradycardia due to parasympathetic activation in OP poisoning. ECG finding can also include a prolonged QTC interval, elevated ST segments, and inverted T waves. Imaging such as MRI or CT scans may be ordered to assess overall health and rule out other conditions with similar symptoms. An electroencephalogram and nerve conduction studies can be performed to further assess neurological function in certain cases. Immediate and systemic treatment is a paramount in organophosphate poisoning. Let's begin with immediate first aid and decontamination. Safety first. Anyone assisting an exposed person must prioritize their own protection to avoid secondary contamination. This often means wearing appropriate personal protective equipment, then remove from exposure, move the victim to fresh air immediately if inhalation occurred. If in an enclosed area, rescuer should wear proper protective equipment. For skin exposure, if OPs contact the skin, drench the affected area with water, remove all contaminated clothing, and wash the skin and hair thoroughly with soap and water. Contaminated clothing should be discarded or thoroughly washed separately to prevent further exposure. For eye exposure, hold eyelids open and gently flush the large amount of clean running water for at least 15 minutes. Remove contact lenses if worn and if easily removable. Care should be taken to avoid contaminating the unaffected eye if only one is exposed. Cover the eye with clean cloth and seek medical attention immediately. For ingestion, activated charcoal. If ingestion is recent, within 1 hour, the patient is conscious and cooperative and has an intact gag reflex, may be considered to absorb the OPs in gastrointestinal tract. However, it should only be administered after a consultation with the poison control center or medical toxicologist, as there is ongoing debate about its routine use. Gastric levels should be considered only if significant quantity of OPs has been ingested and the patient present within 30 minutes of ingestion. This procedure should only be performed if the patient is intubated to protect the airway and is fully resuscitated and stabilized. Finally, inducing emesis or vomiting is generally contraindicated due to the high risk of aspiration, especially in patients with altered mental status or seizures. For general supportive care, have the victim lie down, loosen clothing and keep them warm and quiet, protect the head if convulsing and ensure a clear airway. Now let's turn to pharmacological treatment starting with atropine. Atropine is a competitive and reversible antagonist of muscarinic receptors. It blocks the effects of excess acetylcholine at these sites, effectively reversing muscarinic symptoms such as bronchoria, bronchoconstriction, bradycardia, salivation, meiosis, and gastrointestinal hypermotility. It's important to note, however, that atropine does not reactivate acetylcholinesterase and does not elevate nicotinic effects like the muscle weakness or paralysis. For adults, doses are titrated to until respiratory secretions clear, bronchoconstriction resolves, and heart rate normalizes, aiming for heart rate greater than 80 to 100 beats per minute and pupillary dilation begins. The initial intravenous dose is typically 2 to 5 milligrams, repeated every 3 to 5 minutes. Signs of adequate atropinization include dry skin, dry mucosa, decreased bowel sounds, mydriasis or pupil dilation, and tachycardia. A maintenance dose of 20% of the initial atropinizing dose per hour is often given for the first 48 hours and gradually tapered over 5 to 10 days. For a pediatric patients, a trial dose of 0.01 to 0.02 milligrams per kilogram can be used as a diagnostic aid. The initial intravenous dose is 0.05 milligrams per kilogram, repeated every 3 to 5 minutes. The dose should be double every 3 to 5 minutes until the muscarinic symptoms resolve. The maximum single dose in children for OP poisoning is 0.5 milligrams. For children 12 years or older, the initial intravenous dose can be 1 to 2 milligrams. The goal is to achieve full atropinization, ensuring cardiovascular and respiratory stability. While atropine is essential, caution is advised to avoid exceeding recommended doses, especially in children, due to the risk of severe anticholinergic effects. Next, we discuss pralidoxime, often known as 2-PAM. Pralidoxime is a cholinesterase reactivator. It works by binding to the organophosphate molecule and facilitating its removal from acetylcholinesterase enzyme, thereby reactivating the enzyme primarily outside the central nervous system. This action directly reverses both muscarinic and nicotinic effects, including muscle weakness and paralysis. Pralidoxime is the most effective if administered early, generally within 24 to 48 hours of poisoning, before the organophosphate acetylcholinesterase complex undergoes aging, an irreversible change. For adults, a common regimen involves an initial 1 to 2 gram intravenous loading dose over 30 minutes, followed by continuous infusion of 500 milligrams per hour. Some studies suggest higher doses for moderately severe cases or 8 milligrams per kilogram per hour as recommended by WHO guidelines. For a pediatric patient, doses is typically 25 to 50 milligrams per kilogram intravenous bolus over 15 to 30 minutes, followed by infusion of 10 to 20 milligrams per kilogram per hour. The role and optimal dosing of pralidoxime remain controversial. While it does not depress the respiratory center and can be used with atropine, some systematic reviews and meta-analysis suggest it may not significantly improve outcomes or prevent mortality and may even cause harm in certain populations, especially with high doses. Currently, low dose 1 to 2 grams low IV 2-PAM is often recommended. Pralidoxime should not be used for carbamate intoxication. Rapid intravenous administration should also be avoided due to potential adverse effects. We also use benzodiazepines such as diazepam or lorazepam. Benzodiazepines primarily act at the GABA receptor, enhancing the inhibitory effects of GABA in the central nervous system. This action helps to control seizures and alleviate agitation. They are administered intravenously to control seizures. The specific dose depends on the patient's age, weight, and clinical response. Contraindication include known hypersensitivity reactions, angle-closure glaucoma, and history of hypersensitivity to dextran 40. Anaphylaxis and angioedema have been reported with their use. Beyond specific antidotes, robust supportive care measures are critical. For respiratory management, airway protection and oxygenation are paramount. Patients with respiratory distress, laryngospasm or bronchospasm, bronchoria or seizures often require endotracheal intubation. High flow oxygen should be administered. Mechanical ventilation is frequently necessary for severe cases of OP poisoning that lead to respiratory failure due to muscle paralysis, bronchoconstriction, and central respiratory depression. Ventilator settings such as synchronized intermittent mandatory ventilation with pressure support should be carefully chosen and titrated, often with positive and expiratory pressure to maintain oxygen saturation above 94%. Monitoring, close monitoring of respiratory parameter is crucial. Vigilant monitoring for respiratory infection like pneumonia, a common complication, is necessary with early intervention with antibiotics if indicated. For fluid and electrolyte management, maintaining adequate hydration and correcting any electrolyte imbalance are critical, as this can be exacerbated by excessive secretions, vomiting, or diarrhea. Intravenous fluid should be administered carefully to avoid fluid overload, especially in patients with cardiac compromise. Close monitoring of electrolyte levels is also important. Cardiac monitoring and intervention. Continuous cardiac monitoring is essential. Organophosphate poisoning can cause bradycardia, which is common, and sometimes tachycardia obtained due to atropine, as well as arrhythmia like prolonged QTC interval, elevated ST segments, and inverted T waves. There should be managed as per advanced cardiac life support guidelines. Temperature regulation. Patient may experience hypothermia due to vasodilation or hyperthermia, especially during severe poisoning or with excessive atropinization. Maintaining normothermia is vital to prevent complications. Management of intermediate syndrome. This syndrome typically develops 24 to 96 hours after acute symptoms resolve and characterized by delay paralysis, particularly of respiratory and proximal limb muscles. Patients with intermediate syndrome require continued intensive care, including ventilatory support. Beyond standard care, several advanced and emerging treatment strategies are being explored or utilized. Hemoperfusion is considered for adult patients with severe OP poisoning, especially when traditional treatments are insufficient. Specific indications include cases involving lipophilic OPs, coma, the need for ventilator support, persistent symptoms despite antidotes after 12 to 24 hours, profoundly low cholinesterase levels, acute kidney injury, or acidosis. It has shown promise in removing OPs from the bloodstream, particularly for highly lipophilic compounds, and can lead to clinical improvement. Plasmapheresis, while not as commonly cited for OP removal as hemoperfusion, could theoretically be considered to remove protein-bound OPs or circulatory inflammatory mediators in severe cases, though direct evidence for its routine use is limited. Glycopyrronium bromide or glycopyrrolate is an anticholinergic agent similar to atropine but with less central nervous system penetration. It may be considered as an alternative to atropine to manage muscarinic symptoms with a potentially fewer CNS side effects. Magnesium sulfate is thought to have neuroprotective effects and may modulate acetylcholine release and sensitivity. Clinical trials suggest it can be beneficial and potentially leading to decrease in hospitalization duration. A protocol involving intravenous infusion followed by a successive injection has been studied. Ketamine, an NMDA receptor antagonist, has neuroprotective properties. Its addition to standard of care countermeasures for acute poisoning has been shown to improve neurobiological outcomes. Finally, organophosphorus hydrolases represent a promising emerging therapeutic strategy. These enzymes are capable of directly degrading OPs, thus detoxifying them before they can inhibit acetylcholinesterase. Research is ongoing, but they are not yet in routine clinical use. The impact of organophosphate poisoning can extend far beyond the acute phase, leading to significant long-term effects and complications. A severe sequela is organophosphate-induced delayed neuropathy or OPDN, also known as polyneuropathy or OPDP. This is an axonal polyneuropathy that typically emerges weeks, specifically 1 to 4 weeks, after exposure to certain OP agents. It involves the distal degeneration of some axons in both the peripheral and central nervous systems, particularly affecting the spinal cord. Symptoms are primarily motor focus, often presenting as distal weakness and sensory loss. Initial signs include cramping muscle pain in the lower limbs, distal numbness, and tingling. This followed by progressive weakness, depression of deep tendon reflexes, foot drop, potential progression to flaccid paralysis in all four limbs, or quadriplegia. Sensory disturbance can include muscle cramps, tingling, and burning pain in a close and stalking pattern. Pyramidal signs indicating upper motor neuron involvement can also develop in severe cases. The prognosis is typically incomplete, with motor neuropathy often persisting, while peripheral nerve function can show significant recovery. Severe cases may result in permanent spastic ataxia due to pyramidal involvement. There is no specific treatment for OPDN. Rehabilitation therapy and proper nursing care are crucial. Beyond OPDN, chronic exposure to even low doses of OPs can lead to a range of other neurodevelopmental and neuropsychiatric issues, including dementia, attention deficit hyperactivity disorder, neurodevelopmental issues in children, autism, cognitive developmental problems, Parkinson disease, elevated rates of neurological symptoms, and poorer performance on neuropsychological tests. It can also lead to chronic organophosphate induced neuropsychiatric disorder. Long-term complications are not limited to the nervous system. Respiratory complication can include aspiration pneumonia, respiratory failure, severe bronchospasm, and fluid accumulation around the lungs. Possible long-term cardiovascular system impacts have been noted. Some pesticides, including organophosphates, can act as endocrine disruptors, potentially affecting hormonal balance. And finally, elevated rates of psychiatric symptoms such as memory loss and psychosis are observed years after acute exposure. The severity and persistence of these long term complications depend on the specific OP compound involved, the dose of exposure, and the duration of the exposure. Prevention is a key to mitigating the risk of organophosphate poisoning. This involves strategies at both the personal and community levels. Let's start with the personal and household prevention. Always wear protective gear such as gloves and masks when working with pesticides. Decontaminate after use by removing any contaminated clothing before entering your home. Then shower or bath and wash your hand thoroughly, especially before eating or drinking. Wash work clothes separately from other laundry to avoid cross contamination. Always secure chemicals, keeping all pesticide product out of reach of children and in securely stored locations. Wash produce thoroughly before eating to remove potential residues and clean up properly to discarding or cleaning pesticide contaminated containers and equipment separately and according to guidelines. Now for environmental, community and workplace prevention. If there is pesticide spraying in your area, stay indoors with the windows closed to minimize inhalation exposure. If you use well water, test it regularly for contamination. Whenever possible, reduce the use of toxic products. Many OPs have been banned or are in those process of being phased out. And consider promoting or consuming organic produce to further reduce exposure risk to pesticides. For personal protective equipment for workers, individuals working with organophosphates must wear full protective gear, including gloves, protective clothing, respirators, and eye protection both during and after application. It is essential to ensure that appropriate PPE is available and used as specified by the product label instructions. Understanding organophosphate poisoning from its myriad sources of exposure and insidious mechanism of action to its vast spectrum of clinical features, detailed diagnostic processes, comprehensive treatment protocols, and profound long term complications underscores the clinical importance of prevention. By adhering to safety guidelines and promoting awareness, we can collectively reduce the incidence and devastating impact of this global health challenge. Thank you for joining the Docsaab's diary on this in depth exploration. Stay informed, stay vigilant, and remember knowledge is a powerful tool for health and safety. Like, share, and subscribe for the more insightful discussions. And always, if you suspect organophosphate exposure, seek immediate medical attention. Thank you, guys.